Good evening, folks. Give me a minute, I'll set up. Good evening, folks. Tonight's topic C talks about hospital associated deconditioning, a fast, often preventable loss. A fast, often preventable loss of strength, thinking, and clarity and independence, but families who push for mobility, sleep, protection, medication cleanup, and rehab can dramatically change the outcome. What this overlooked risk really is. Hospital associated deconditioning isn't just getting weak, it's a whole body syndrome that can unfold shockingly fast. Sometimes that can unfold shockingly fast within 48 to 72 hours of lying in a hospital bed. Research shows that up to 30% of older adults experience significant functional decline during or after a hospital stay. Acute muscle loss, acute sarcopenia. The legs weaken first, making standing and walking harder. Cognitive deconditioning, slowed thinking, poor attention, or delirium. Loss of independence, difficulty with bathing, dressing, toileting, or managing medications. Higher risk of readmission or long-term care placement. These declines are not just old age, they are psychological consequences of our physiological consequences of hospitalization, and many are preventable. Why this happens? The hospital environment itself can cause harm. Even when the medical care is excellent, the environment works against recovery. Bed rest triggers rapid muscle breakdown. One study found 1 in 5 older adults develop new sarcopenia within a week of hospitalization. Sleep disruptions from alarms, vital sign checks, and noise impairs hearing and cognition. Sensory deprivation, missing glasses or hearing aids, increases delirium risk. polypharmacy, especially sedatives, anticoagulants, and steroids worsens confusion and muscle loss. Unfamiliar routines, reduced autonomy and confidence. Hospitals Hospitals save lives, but they are not designed for maintaining function. How families can protect their loved one? The most effective actions. These steps are simple, powerful, and supported by evidence. 1. Insist on early and frequent mobility. This is the single strongest intervention. Ask nurses to help your loved one sit up for meals, walk 2 to 3 times daily, and avoid long stretches in bed. Request PT/OT within 24 hours of stabilization. Even if leg lifts, ankle pumps, and seated marches help preserve muscle. Protect the brain, prevent delirium. Bring glasses, hearing aids, and dentures, and large face clock. Keep the room bright during the day and quiet/dark at night. Reorient gently. It's Tuesday morning. You're in Meadville Medical Center, and you're here because ask the team to avoid unnecessary nighttime vitals or labs. 3. Clean up the medication list. Ask daily which medications can we stop. Flag sedatives, anticholinergics, and unnecessary opioids, all linked to delirium and falls. Support nutrition and hydration. Encourage protein at every meal. Bring preferred snacks if allowed. Ask for a dietitian. Consult if appetite is low. Plan discharge early and push for rehab. If walking, balance, or self-care have declined, request inpatient rehab, skilled nursing rehab, or home PT/OT with a clear schedule. Early rehab reduces long-term disability and rehospitalization. Key questions to ask the care team. Has PT/OT evaluated them yet? What's being done to prevent delirium? Which medications can we safely stop? What is the plan for rehab after discharge. What is the follow-up appointment scheduled? When is the follow-up appointment scheduled? Red flags after discharge. Seek urgent care if you see new or worsening confusion or hallucinations. Inability to stand or walk. New falls, fever, dehydration, or inability to drink, eat, or drink. Sudden shortness of breath. Hospitalization treats the illness, but without vigilance, it can unintentionally steal strength, cognition, and independence. Families who advocate for mobility, sleep, sensory support, medication review, nutrition, and rehab can dramatically improve recovery and reduce long term disability. Hospital associated deconditioning, or HAD, is, is a whole body, whole mind syndrome that strikes hardest in older adults with frailty. It blends rapid muscle loss, slowed cognition, or delirium, and multi-system vulnerability. The article argues that only early coordinated action, mobility, mobility, sensory support, medication cleanup, nutrition, and structured care bundles can prevent this decline from becoming long-term disability. Okay, here's the rest of it, guys, for you. The authors of New Horizons in Hospital Associated Deconditioning, a global condition of body and mind, make a bold claim. We have been underestimating what happens to older adults in the hospital, what has long been labeled as deconditioning is not simply a matter of being out of shape or needing a bit of rehab. Instead, they describe a multi-system syndrome that unfolds rapidly and often silently. Definition and scope. HAD encompasses two intertwined processes: acute sarcopenia, a precipitous drop in muscle mass and strength, can occur within days of bed rest. This affects gait, balance, and ability to perform basic activities like standing, toileting, or dressing. Cognitive deconditioning, slowed processing, uh, inattention, disorientation, and delirium spectrum syndromes. The authors emphasize that this cognitive component is not secondary or optional. It's it's central to the syndrome. By reframing HAD as a global condition, the authors argue that the term deconditioning is misleading. It implies a reversible fitness related issue, when in reality, the underlying changes often reflect organ level dysfunction, neuroinflammation, and systematic stress. Who is most at risk? The article highlights clear pattern. Frailty is the amplifier. Older adults with frailty experience lower psych, uh, psychological reserve, slower recovery from stress, higher vulnerability to immobility, sensory deprivation, and polypharmacy. Other high risk groups include people with pre existing mobility limitations, cognitive impairment or dementia, poor nutritional status, depression or low mood, heavy medication burden, especially sedatives. These factors interact, creating a downward spiral that can begin within 48 to 72 hours of hospitalization. Why this matters so much? The consequences of HAD extend beyond the hospital stay. Prevent disability. Many patients never return so to their pre-hospital baseline. Loss of independence, increased need for caregivers, assistive devices, or long-term placement, higher readmission rates. Functional decline is a major driver of rehospitalization. Cognitive after effects, delirium, and cognitive slowing can linger for months. The authors argue that focusing solely on physical rehabilitation is insufficient. HAD is multidimensional, and must must be the response. Recommended interventions expanded and evidence based. The article outlines a set of interventions that work best when implemented immediately and together. Early frequent mobilization. Sit up for meals. walking multiple times a day, and PTOT within 24 hours of stabilization. Even small movements, ankle pumps, seated marches, slow muscle loss, delirium prevention, and sensory support, glasses, hearing aids, dentures, clocks, calendars. Bright days, dark nights, minimizing nighttime disruptions, reorientation and family presence when possible, medication review, daily deprescribing conversations, avoid sedatives and unnecessary opioids, simplify regimens to reduce cognitive burden, nutrition and hydration optimization, prioritizing protein intake, and early dietitian involvement. Okay, guys, that's your C for tonight. I will see everybody Monday for shows. Until then, Gator Wellness. Take care, folks.